the bicycle helmet. So we've been doing a lot of work on the foot and ankle for over 40 years in Leeds. And as I say, we've been trying to educate people as to how to examine the foot and ankle. And we run the course, which it's run over 2 days. So I'm now going to give you a 2 days worth of information in 30 minutes or less, maybe. So hang on to your seats and just get a flavor of what we do in this course. And of course, we teach people to look, feel, and move. And there's absolutely no point in doing this unless you can remember what your anatomy taught you all those years ago. So we spend the first half day revising the anatomy of the foot and ankle. And then we move on to patients and we teach how to look and where to look for pathology. And we're talking about joints, ligaments, tendons, and other aspects, but those are the main three: joints, ligaments, and tendons. And we tell people how to examine the foot and ankle, particularly around the ankle, because it's a complex joint: tibio-talar joint, subtalar joint, and the talonavicular joint, the mid-tarsal joints are very complex joints to examine. And we teach them how to move the joints and look for restrictions in biomechanics there. And as I say, we revise the anatomy. I put up this slide and I ask people to name what the numbers are. And I'm not asking you to do that now, but this is the part of the revision that we go through, because people have forgotten all this when they come to our clinic. The major tendons of the body, as you can see illustrated in the picture on the right. And surface anatomy is very important, and particularly for when you come to start sticking needles in people. And we teach conservative management, which is, of course, treating the disease behind the problem, but also local steroid injections. And if you don't know your anatomy, you can't do them unless you send them to your radiologist who's got an ultrasound probe or whatever. But they can be done blind very easily, but not unless you know what you're doing. So we teach the bony landmarks and where to put needles in to the subtalar joint, tibio-talar, talonavicular, the various enthesopathies, and so on. Here's one very important landmark. If you take your own foot and ankle and find your lateral malleolus and just press a little bit forward of that, there's a big dimple in your foot called the sinus tarsi, and it hurts. It's like the anatomical snuff box in your hand. But this is an important landmark because this structure, the sinus tarsi, enables you to inject the subtalar joint with ease. And if you can't find that, then you can't inject the subtalar joint. And similarly, on the inside of the ankle, you've got the tibialis posterior tendon, one of the most important tendons in the body. We saw someone on the ward this morning with ankylosing spondylitis who, quite by chance, had a tenosynovitis in his tibialis posterior tendon. So this is an important tendon to look for. And round the inside of the ankle, you've got the tarsal tunnel. Tarsal tunnel syndrome is like carpal tunnel syndrome, except you get symptoms in the foot, but they've got the same periodicity, and you get pins and needles down the inside of your foot to your great toe. And through the tarsal tunnel passes the tendons of tibialis posterior, flexor digitorum longus, and flexor hallucis longus. And when you get tenosynovitis in any of these tendons, particularly tibialis posterior, the tarsal tunnel swells and you get tarsal tunnel syndrome. And podiatrists like to identify these tendons as T for Tom, D for Dick, and H for Harry. Tom, Dick, and Harry. In the front of the ankle, if you just pull your foot back a bit, you'll find that big tendon called tibialis anterior. This is also an important landmark because if you just put your finger medial to that tendon, there's another hole, and this is the entrance to the tibio-talar joint. So all these important landmarks and anatomy we teach in the first half day. And then we go on to general examination of the foot, and we always recommend looking at the gait, because the foot, although it's a distant part of the leg, is connected to the rest of the body, and you've got to know what's going on in the knee and hip to examine the foot function properly. And we look at the footwear. You probably don't have that same challenge here, because I've been noticing a lot of patients in flip-flops over in the clinic. But my patients come, well, some of them come in their best Sunday shoes that they never wear, so they don't see these patterns. But if they come in their everyday shoe, you'll see wear patterns such as the ones I'm illustrating here. And if you look inside the shoe and take the insole out, you can see where the wear is occurring and whether it's bulging. So that's another important aspect to the initial approach. So let's just go on to disease-specific considerations. And the first one I'd like to talk about is rheumatoid arthritis, because this is where we've done a lot of work on the foot and ankle in rheumatology. And if you look at the symptoms that people present with rheumatoid arthritis, this top right-hand graph, the hand is the commonest presentation for rheumatoid, but followed closely by the foot and ankle, I should say. And if you look within the foot and ankle, the most common symptoms at the front of the foot rather than the rear of the foot. And that's slightly different, as we'll see in a minute, for spondyloarthritis. So it's forefoot problems. And the people who see these patients are not necessarily doctors. Often podiatrists will see these patients first. So we teach a lot of podiatrists as well about how to identify problems in the foot and ankle. And in early disease, you get the swelling in the metatarsophalangeal joints, as I've just described. That causes what's called the daylight sign, where two toes will be pushed apart by the synovitis within the adjacent MTP joints. You can only really look at a daylight sign when you're non-weight bearing, but this was taken incorrectly, I think. But there's the daylight sign down there between the second and third toes. And you'll see that the rear foot starts to come over and pronate. And if you examine this patient, they're weight bearing there, but if they're non-weight bearing, there's no deformity and you've got a normal subtalar movement. But it's this early stage that you are you're more susceptible to treatment with mechanical correction, insoles. And there's good randomized control evidence that if you fit an insole in this patient in early disease where the deformity is correctable, you will prevent that deformity progressing. Don't forget, the principles of treatment of inflammatory arthritis include joint protection. It's very hard to protect the joints of the foot because you're walking on them all the time. But one way of protecting them is to use orthotic devices that can correct the deformity. I've stopped moving on here. Don't know why. Oh, it's all moved. No, it's all gone. I'm having technical problems, guys. Can you get me back into the presentation? So a lot of the work that we do in early rheumatoid arthritis is to correct that mechanical deformity and to use specific anti-inflammatory therapies like local steroid injections and systemic therapies that you would use for any patient with rheumatoid. So it's important to control the disease generally as well as to control it locally. The problem is, of course, that as the disease progresses, the deformities you see in the foot become permanent and non-reducible. And ultimately, when the deformity is severe, you're looking at surgical correction rather than medical correction. And I fear that my presentation has defeated you. Okay, so just to summarize the principles of treatment of rheumatoid, then it's mechanical correction, general disease control, and local disease control. And those principles apply across all inflammatory articular diseases, not just rheumatoid arthritis. And as some of you may know, one of my special interests is spondyloarthritis. And I wanted to describe to you the changes that you'll see in spondyloarthritis.
Keyboard locker.
And they're hard to describe without pictures, really, but the specific features of spondyloarthritis, particularly psoriatic arthritis, are synovitis, as you get with rheumatoid, enthesitis, dactylitis, and the skin and nail changes that you see with psoriasis.
Okay.
Okay. I think we're there. Yeah. Okay.
So
Yeah. Yeah, so we're back to the early disease of rheumatoid again. And I described the daylight sign and the rear foot pronation, and you also get a widening of the foot. And if you look from the back, you'll see that pronation, and you see the bulging here on the left, which is due to tibialis posterior tenosynovitis, very common in early rheumatoid. So in early disease, you've got pre-existing deformity. Lots of hallux valgus occurs in the UK. But patients come in complaining of pain under the metatarsal heads. They say it's like walking on pebbles, doctor. You get tenosynovitis, as I've described, and poor rear foot alignment, and the medial arch will drop. And as the disease progresses, then these changes become more prominent, particularly the rear foot collapse. And you'll see, as you would have seen it, you've been on the course, that we have the navicular bone here, which is now becoming less supported by the ligaments and sinking towards the ground. And you'll see that we're beginning to see hammer and hammer toes appearing at this stage. And if you look underneath the foot, very important, you'll see callus formation where the pressure is higher, here represented in the 4th and 5th MTP joints. And of course, as the disease progresses, the navicular drops completely, so that you're walking on your navicular. The toes disappear and stop being weight-bearing and become deformed. Okay. Oh, okay. Thank you. Thank you. So you see here that the toes are non-weight bearing now. They're risen off the ground. The metatarsal pad has been displaced, and these deformities are not correctable. So at this point, you're looking at surgical correction if you're going to help this patient. What else can you get in rheumatoid? Well, you can get enthesitis. It's not the province of spondyloarthritis. You get bursitis, here demonstrated in the retrocalcaneal bursa. Tenosynovitis, as I've said. Patients present with like Morton's neuroma, so they get paresthesia in the 3rd and 4th toes, That's not due to a neuroma, that's due to bursitis in the intermetatarsal bones. Rheumatoid nodules we're seeing much less of nowadays, but that can also cause the Morton's neuroma-like symptoms. And of course, as disease progresses, you get vascular and neurological problems. So psoriatic arthritis, as I said, my special interest, more rear foot than forefoot disease. And particularly what we're looking for is enthesitis. The foot is a rich source of entheses. And if anything is going to be affected in this disease, it's the foot because of all those enthesial sites, which I'll come to in again. So the prime enthesial site of the body is here at the Achilles insertion. I'm often sent patients with psoriasis who've got problems here. Up this part, this is mid-portion Achilles tendinopathy. This isn't related to the psoriatic arthritis. It's when it's down here at the insertion that you're interested in this condition. Of course, dactylitis is just so obvious when you see it that you can't miss it. And in this case, this patient's got a swollen DIP joint in the second toe, not dactylitis. This patient of mine has bilateral insertional Achilles tendinitis, Achilles enthesitis, I'm sorry. A really severe case, and the skin's not too good either, as you can see. And you'll notice there's a scar there. Why is there a scar? Because she ruptured her Achilles tendon. Why did she rupture it? Because somebody thought it was a good idea to inject steroid at the enthesis. Not a good idea. We don't inject the enthesis of the major tendons. Here's a patient that came in saying, "Oh, doctor, I've got some pain on the lateral foot just here." And I looked at his foot and he'd got a little bit of swelling just at the insertion of peroneus brevis. This is why you need to know your anatomy. And I took an x-ray and it doesn't look to be much here, but if you blow it up, you'll see he's got periostitis at the base of the fifth metatarsal. This is a common enthesial site in psoriatic arthritis. And sesamoiditis is also quite common, and this is underdiagnosed. Here's a patient who had it and had modified his own insoles to try and take the pressure off his sesamoid bones. But sesamoiditis is not an uncommon feature of psoriatic arthritis. And of course, nowadays you get arthritis mutilans, but much less commonly than we used to do. So you'll see here the bones are osteolytic and the toes are retracted as a result of that osteolysis. But I think this is a disappearing disease now because we're treating more aggressively. And then there's the Bauer digit. This is a peculiar manifestation, basically swelling of the great toe with an affected nail here with onycholysis. And this can be sometimes the only presentation of this disease. And this particular patient was a big wig in where I come from as a company director. He couldn't do business because he couldn't get on the golf course because his big toe was swollen. So I injected his big toe, the interphalangeal joint, not an easy thing to do. And he got good relief and he came back and had another injection and then he disappeared. And he came back about 4 years later looking really fit and healthy. And he said he'd retired and gone to Thailand and he was stung by a scorpion. He said that did the trick. So I looked up, I must acknowledge Walter Bauer, who first described that digit. But I looked up local remedies for arthritis in the Lake District where I come from. And these are some of them. Wrap an eel's skin around the limb, soak cod entrails in a bucket and drink it. With toothache, rub the child's teeth with the brains of a hen. But if you arrange to be stung by bees, you can get rid of your arthritis. And I think this is what this guy did. He got stung by a scorpion. So what about ankylosing spondylitis? Again, the rear foot much more commonly than the forefoot. And enthesopathy, particularly around the calcaneum, the plantar fascia and the Achilles insertion. but also it can affect the mid-tarsal joints, particularly in the younger patient, like Reiter's disease used to do, so they get collapse of the midfoot. And in this cross-sectional study from France, the prevalence of heel pain was almost half the people had heel pain, mostly at the plantar fascia, but not so far behind the Achilles tendon. And these patients are very resistant to treatment with NSAIDs and conventional DMARDs. Not until you give them a TNF inhibitor will they improve. We see a bit of gout, but mostly we don't see this, acute gout. I don't know whether you do or not, but acute gout is all treated in primary care in the UK and commonly affects the first MTP joint, but can affect any joint in the body. So don't forget acute gout. If you're in doubt, aspirate and look for crystals. But this is what we see, chronic tophaceous gout. This case being a rather extreme example of tophi in the hand. But here's a guy I saw. He came along with a dactylitic second toe. He didn't have psoriasis. He had a little leak from the tip of his toe. And I swabbed the leak and took it and put it under my microscope. And there he had uric acid crystals. So this is a case of uric acid dactylitis. I had a similar patient who went to see an orthopedic surgeon and said, oh, you've got infection, and chopped it off. Because he can do without the odd toe. So he lost his toe when he should have really had allopurinol treatment. And of course, you can get tophi in the heel, in the Achilles tendon, if you sometimes. So my time's up according to this dial, and that was a whistle-stop tour of the foot and ankle in rheumatology. But we call the foot and ankle the gateway to the body. Don't forget that. In rheumatoid, it's mostly the forefoot, not the rear foot. In opposite, in spondyloarthritis. And you always have to do biomechanical considerations when you're treating problems in the foot and ankle. You can't just inject and say goodbye to the patient, because they'll come back with the same problem unless you can do a biomechanical correction as well. So thanks for your attention. I hope it wasn't too disrupted by the technology. Thank you.
One change in the order. Call Dr. Ruchika and Dr. Achi, and then because we have to leave, can introduce Dr. Ruchika and Dr. Achi.